My name is Dr. Michael David. I'm joining the faculty at the University of Chicago in order to continue my studies on the epidemiology of methicillin-resistant Staphylococcus aureus. So methicillin-resistant Staphylococcus aureus was once confined to groups of people who had a lot of exposure to the healthcare system and hospitals in the United States. And about a decade ago, in the late 1990s, it was recognized that new groups of people were developing MRSA infections. And these groups of people didn't necessarily have any exposure to the healthcare system. They weren't necessarily people who had chronic illness or had to be hospitalized for long periods of time. Over the past decade, specific groups have been recognized as being at high risk for developing these infections, particularly skin infections with MRSA. These groups have included detainees in jails and prisons, and that's one of the groups that we focused some of our research on at the University of Chicago. Other groups include military trainees in basic training and in barracks. Sailors on submarines are included in that category. In addition to that, there have been outbreaks on athletic teams, from professional athletic teams, college athletic teams, high school athletic teams, and these have been recognized all over the United States. Other groups have included children in the inner city, and we've seen a number of cases like that, in fact a flood over the past decade. Another risk group are men who have sex with men and patients who are infected with HIV. To study the epidemiology of an infection is a very complicated task. Governments, including the United States government, have programs to track the spread of bacteria and the spread of viruses that commonly cause disease, particularly for viruses and bacteria that can be prevented in some way. In the United States, the Centers for Disease Control and Prevention has a program that tracks serious infections caused by MRSA strains. This is called the Active Bacterial Core Surveillance Program. This program is excellent and provides data that represents serious invasive MRSA infections as they're reported by a sample of hospitals in the United States. The limitation of that surveillance program with regard to community-associated MRSA strains is that the vast majority of infections caused by community-associated MRSA strains are skin infections, and the vast majority of them are fairly simple and can be treated well by a doctor in the community. Because of that, the vast majority of people who get skin infections caused by community-associated MRSA strains don't go to the hospital. They aren't admitted, and their infections get better before they turn into an invasive or serious infection. People with skin infections like this are not captured by the surveillance program carried out by the Centers for Disease Control, and there have been very few studies that have attempted to determine how many people in the United States, for instance, get a skin infection caused by community-associated MRSA strains. So there's still much research to be done to understand the epidemiology of community-associated MRSA, particularly in regard to these simple skin infections.
Hello, my name is Dr. Robert Dom. I'm a professor of pediatrics and microbiology at the University of Chicago Medical Center. I'm the principal investigator and the director of the MRSA research program that we've established at the University of Chicago. The community-associated MRSA epidemic and the rapid increase in the prevalence of MRSA infections in any setting has put tremendous pressure on clinicians to think about how they want to treat MRSA infections. There's, broadly speaking, two arenas where this problem really focuses. Arena number one is the community, where with the loss of being able to routinely use beta-lactams, that is to say penicillins and cephalosporins, we've had to dust off old antibiotics that are so old they've lost their patent, such as clindamycin and trimethoprim, sulfamethoxazole, or Bactrim, and use them to treat community-associated MRSA infections. There has been some progress with developing some new agents for outpatient treatment of community-associated MRSA infections, but this progress has been slow. The regulatory pathways are very complicated, and it's produced compounds that tend to be very expensive and have resistance and toxicity problems of their own. For inpatient treatment, the situation is even more complicated because we've relied on vancomycin, a glycopeptide antibiotic, the only antibiotic of its class that's licensed in the United States. We've relied on vancomycin for many years to be the workhorse of inpatient therapy, that is to say someone sick enough to be hospitalized for a MRSA infection. But vancomycin is getting tired. There are many signs of global resistance rising to vancomycin at a relatively low level, but just high enough to make them difficult to treat. There have been 3 or 4 compounds that have been brought on the market to try and take the place of vancomycin, but none of them has done it adequately. They all have their flaws and they all have their weaknesses. So there is no doubt that one of the problems of dealing with a rapid rise in MRSA infections, both in the community, in the community, I should say, has been to develop new treatment strategies. Marketing and developing new antibiotics has slowed. It's slowed because, for a variety of reasons. One is that big pharma, the companies that make new antibiotics, have been reluctant to take high risk in developing new compounds and bringing them to market. It's an expensive, very arduous process that is highly regulated, and many companies have just said, we don't need to do this. There are other ways for us to make money. So it's been very slowly, we've looked to them for leadership in the past for bringing new compounds to market, but this willingness to take risks has greatly diminished. And so what's happened is people have focused more on small companies, startup biotech companies, and investigators at universities to bring promising ideas forward for new therapies. And then this process has even added another layer of complexity by being slow and needing to transition to big pharma before coming to market. So the question really is, we have to think about how best to treat MRSA infections. And this is a challenge. We need better antibiotics, we need new antibiotics, and the process of developing them has slowed. Pediatricians like me think about preventing infections as the ultimate strategy. The best infections I've ever seen are the ones that I don't see because they don't occur. And there's numerous examples of the development of amazing vaccines that have really been termed by the CDC as the most important clinical development of the last century. It's my belief that this community-associated MRSA epidemic has reached a proportion, magnitude, that we now need to start thinking aggressively about preventing these infections. The best way I know to treat them, to prevent them, is with a vaccine. We can certainly do a number of local things in our houses, in our facilities, cleaning our surfaces better, cleaning our bodies better, covering our MRSA infections. These will have impact, but the real impact comes from a vaccine. If we're all immune to MRSA infections, we will not get them. So the problem if we have, of course, is that Staph aureus, MRSA in particular, is very well adapted to living on humans. The organism has been living with us, on us for centuries, and has multiple systems for doing all of the tasks a germ needs to do, a bacterium needs to do, to go about its daily life. And so taking away any one of these functions with immunity, i.e. putting a component in a molecular feature in a vaccine, will not solve the problem. We need a carefully thought out vaccine that has multiple components in it and has the resources of our national institutes of health or perhaps big pharma behind it to develop. It's going to be a difficult and arduous process, but the time to start is now. Many patients who have been affected by this community MRSA epidemic have had skin and soft tissue infections. It's the most common clinical manifestation, but they can be nagging and persistent. Problems have arisen because the patient often goes to a doctor who doesn't understand that there's a community MRSA epidemic underway and prescribes one of the old useful beta-lactam antibiotics that are no longer useful. Another problem is that there's something we don't completely understand about these skin and soft tissue infections that is recurrent. The recurrent rate of these community MRSA infections is very high, maybe even as high as 20 or 25%. So patients will have questions. People will feel kind of desperate and frustrated that they can't seem to get rid of this problem in their household. But that is one of the reasons we're trying to do research and communicate via this website so that we can all understand where the good information is and what we need to find out to make it even better.